My video off because we're starting to record, which is good. Because I wanted to be sure that I'm not too glitchy. I live out here in the country and sometimes my internet's not good, especially when it's snowing. That said, I'm not the one talking tonight. Tonight we get to hear from Amy Molesbury Ariola. And as you see in the note that I sent you, someone who really made me feel old today because she told me that I've known her for 20, 23 years or something like that. Amy, oh, there's a picture of her. Is that a picture of her, Ned? I don't know. I think it might be. But at any rate, Amy is someone who some of you may know from around town. She's an amazing biker. For her age, she is, I think, at the top because she's so athletic, having competed against her brother all these years in every single sport. I hear she's a good skier. I can't even imagine keeping up with her. But at any rate, I want to welcome all of you. I'm imagining each one of you sitting by a fire drinking hot chocolate. That's what I'm hoping to do as it's snowing outside. And Amy, take it away.
Thank you. All right, so there's my video. So thanks, Winnie, for the introduction. My name's Amy Ariola. I'm a physician assistant at the Park City Clinic. I work 2 days a week at the family practice. And then I also work at our urgent care, Instacare clinic, and the work injury clinic. Before doing PA, I was a ski patroller at Deer Valley, and I did that for 10 years, full-time for a couple of years, and then part-time mostly. So I have a good understanding of what you're doing on the Hill. I try to make my lectures pertinent to what you do on the Hill and give you some good background information and education just so that you have it. And this year I'll be talking about shoulder injuries. And I'll start by covering some anatomy and physiology of the shoulder, give a brief idea of what a clinical exam would look like for me when I see patients that come off of the Hill. We'll talk about acute injuries specifically and go through a scenario and your on-hill assessment that you would do for a patient with a shoulder injury and talk about some important points with transporting these patients. So there's a lot going on in the shoulder. It's one of our most complex shoulder joints. It's the joint that has the most mobility of any of our joints. And because of that, there's a very shallow depth in that shoulder to allow us to have the full range of motion that we have in all the different directions. Because of the shallowness, it's a little bit unstable. And the contact that the humeral head has with the glenoid is only about 25% of the humeral head makes contact. And that's going to be right on that inside joint. Because of that, it's really susceptible to injury because it's unstable. You need a lot of extrinsic support, so a lot of muscles and ligaments to help hold everything in place as it gets the movement that we need to do everything we do. So some basic anatomy, just first starting with bones. And you can see the clavicle here is the main bone, and you can feel that just starting at the center of your chest or your sternum and working out along the clavicle to what we call the acromion, which is part of the scapula that comes and wraps around to the front. And that's the acromioclavicular joint that those two connect at. The scapula itself is the big bone on the back of your shoulder. And then the humerus, the upper part of the humerus or proximal humerus, is what connects in with the shoulder joint. And that's what
Have a good night, you guys.
The shoulder joint. And again, there's 4 different articular or joint areas within the shoulder. Where the sternum starts is where you have the sternoclavicular joint. So again, that's the little bump you can feel right in the center of your chest. The acromioclavicular joint is at the end of the clavicle where it meets with the acromion, and you can feel a little divot there in your shoulder if you push down. The glenohumeral joint is where the glenoid, the part of the scapula, meets up with the humerus, and that's the inside of your shoulder joint. And then there is what we call a scapulothoracic joint, and that's where the back of the scapula meets up with your thoracic or your backside. So the glenohumeral structures and the glenohumeral joint is the most complex and where we see the most going on. Inside the glenoid, you have what's called the labrum, which is a fibrocartilaginous ring that just attaches along that side, inside of the bone. It's kind of like the meniscus in the knee. It's a cartilage substance that can get torn. You also have a labrum in your hip as well, but it's a very cartilage, just like the knee meniscus in the knee. It provides a little bit of additional depth and stability for the shoulder. Outside of that shoulder joint, the extringent support, you have all the different ligaments, the superior, middle, inferior glenohumeral ligaments, and you have your rotator cuff. And the rotator cuff is that group of 4 muscles that attaches and holds the shoulder joint in and help with our movement. So the rotator cuff is your primary shoulder stabilizer, and that's the supraspinatus, infraspinatus, subscapularis, and teres minor muscles. Here you can see the subacromial or subdeltoid bursa. A bursa is a fluid-filled sac that helps with movement and prevent friction. So that helps all those rotator cuff tendons. So the tendon is where the muscle attaches into the bone. It helps prevent friction and pressure. The deltoid muscle is a main muscle within the shoulder as well. That's your primary abductor. So abduction means coming away from your body. And the deltoid is the primary muscle for that. And then of course, throughout the whole shoulder joint, there's a lot of different nerve structures and blood vessels that are part of it as well. So this picture just gives you a baseline, the different ligaments that you can see within the shoulder, and ligaments link bone to bone. So that's what helps stabilize the bone. That's what keeps your scapula from popping way up and holds it down to the acromion. So within the shoulder, there's the coracoacromial ligaments all throughout these different areas here. Oops, go back. There's ligament that attaches at that sternoclavicular area that keeps that sternum from popping forward, or excuse me, the clavicle from popping forward from your sternum. And then the shoulder, the glenohumeral joint, there's glenohumeral ligaments that I mentioned in the other slide that again hold those bones together. This is a view of your rotator cuff muscles and kind of talk about a little bit of the different movements those do. The supraspinatus here at the top, that sits right on top, it's the #1 torn muscle or tendon in the rotator cuff group. And that's the main one that gives you your abduction. Again, that's going away from your body, but only from about 0 to 15 degrees. And then the deltoid, that other muscle I talked about, gives you 15 degrees and all the way up. The subscapularis, which sits on the front side underneath all along this part of the scapula, it attaches. And you can imagine if that muscle tightens, the humeral head is going to do what we call internal rotation. So if you're holding your arm down and your palm's facing forward and that muscle tightens, your whole arm rotates in towards your body. On the back side, there's 2 different muscles, which are the infraspinatus and the teres minor. The infraspinatus is up a little bit higher and bigger, teres minor down a little bit lower. And those, you can imagine, if those tighten up, that humeral head is going to get rotated out, or external rotation. And the infraspinatus is the main muscle for that, but the teres minor does help with that. So those are the 4 muscles of your rotator cuff. There's a picture of the deltoid muscle, and you can see it wraps around all the way along the clavicle in front, around the lateral side or outside of the shoulder. And in this posterior view, it comes along the spine of the scapula. So it's a big muscle that wraps all the way around, and you can see how that gives a lot of strength. And again, that's the one that gives your muscle movement from 15 degrees and then all the way up to your ear for that abduction movement. The scapula does a lot of fun different movements just with how different muscles and tendons are attached to it. So the main movement is it can move up and down a little bit, so elevation, depression. It can do this protraction and retraction, kind of swirly almost type movement. And then you have an upward rotation and a downward rotation. And those movements really help stabilize the shoulder joint as you're moving your arm, especially in that outward movement. That's scapula is one of the biggest stabilizers for our shoulder. This gives you a quick view of the anterior muscles of the shoulder, and this first picture is your superficial muscles. So not only do you have the rotator cuff and the deltoid, but you've got your pectoralis muscles. The trapezius does wrap around the front side. It's mostly on the back. You've got your biceps muscles, serratus anterior. And then a little bit deeper to those, you have some of these other muscles. So the pectoralis minus, the serratus anterior, you can see a little better here, your biceps again. And there's a little muscle here that's called the subclavius right along underneath the clavicle. So all those different muscles help do different movements. And again, just imagine as you look at where these muscles attach to when they tighten, that's where we get our movement. Those muscles tightening will pull and rotate and twist and raise our arm. These are the posterior muscles. Again, the trapezius is this big diamond on the back. You can see the deltoid. Underneath that, the infraspinatus and teres minor of the rotator cuff. There's a teres major. Latissimus dorsi is another big muscle down a little bit lower in the back, but it does attach up onto the humerus. And then you have your triceps muscle, and there's the 3 parts of the triceps. Deeper to that, the rhomboid muscles, and you can see that those attach to that medial part of the scapula. Your levator scapulae. So again, as that pulls up, that's going to do some of that twisting or rotational movement of the scapula. And the other muscles that you can see a little bit better here that were under some of those more superficial muscles. This just shows you the biceps tendon. People think biceps and they often think elbow, but where the tendon crosses over the shoulder joint, it does give us a little bit of movement. The short head attaches right here in front, and that gives you abduction, which is going to be kind of forward or movement, excuse me, back towards your body. And then the long head wraps around a little bit, so that helps abduct or bring the arm away from you. It'll also internally rotate a little bit. And then here's a quick picture of all the different nerves. The nerves come out of the spine, and then they cross out into the shoulder underneath the clavicle, which something to remember with these nerves, and again, the blood flow, is that if there's a fracture, you've got to be worried about nerves. If something's dislocated, can pinch the nerves or damage the nerves as well as blood supply. All right, so I'm going to give you a quick idea of clinical exam, and to do that, I'm going to have my son, John, come and help me. So I'm going to, let's see if there's a way to stop sharing and show my screen. Okay, does that put me in a bigger view, hopefully?
It looks good. Looks
Okay.
good. Let me see John.
All right. All right. There's John. Thank you, John, for helping. So we're going to pretend, come over on this side, that John has an injury to his shoulder. And if I've come into the clinic, the first thing I'm going to do is I usually palpate or push. So I'm going to start right in the center. Again, that sternoclavicular joint, you can feel the depression on yourself. Work my way along the clavicle, and I'm feeling and asking, is anything tender? You feel for any deformities or bumps or lumps. Out to that acromioclavicular joint, the AC joint. Just below the AC joint, you can run your fingers across and you can feel that short head of the biceps. And just outside or lateral to that, you can feel the long head of the biceps. You can kind of run your fingers along there, make sure you feel those, or if there's pain along those. Just on the other side or the lateral side of that AC joint, you have your subacromial bursa. So you can push on there, and sometimes that's more of a chronic issue, but that might be tender as well. And then I'll usually push along the back side of the scapula or the spine of the scapula. You turn around, turn sideways. Perfect. And then I go along the medial side of the scapula and push along the body of the scapula and just check for tenderness. While I'm on the back, I'm usually palpating along the spine, and I check the neck as well, because these injuries can have a lot of times associated injuries with either other muscles. The neck and spine are close there too. All right, turn back around. And then I'm going to ask the patient to do some range of motion for me. If at any point within this, somebody's really tender, I notice a big deformity, I may get an x-ray first and wait to do my range of motion until I know if there's a fracture. I'm not going to do range of motion in someone who I've suspected might have dislocated, or there might be other injuries that would be worsened by any movement. So John, I'm going to have you take both your hands and bring them up beside your ears and drop them down, and bring both your arms up by your ears to the side, all the way up by your ears and down. Perfect. And then I'm going to have you turn to the side again. I have them put your hand behind your back, turn a little more. Both hands behind your back with your palms facing out. Good, and release. Take this hand, put it behind your back and get your thumb as high as you can get it on your spine. Okay, so he's right about there on his spine. Okay, go put this arm down and do the other one. And can you go up? Yep, so we were about the same level. If you get more than 3 spinal processes difference in the level they can bring their thumb, then you're worried about injury within the tendons and muscles. Face forward again. So then I do, we've done range of motion, and then I'm going to do strength. So I'm going to have John put your elbows next to your body, push your hands outward against me, push your hands in against me. Good. Put your hands out in front of you and put your palms up, elbows straight, and push up against my hand. Good. Now turn your thumbs down, elbows straight, and push up against my hand again. Great. I'm going to have you turn around, put your hands behind your back. Turn a little more so they can see your hands. Stand up for a second. And then push away from you with the palms. Perfect. Great. Sit back down. I'm going to take the arm and let you relax it for me. And I'm going to bring the arm up and come down and kind of push forward. And then I'm going to have him relax, and I'm going to be the one to move the arm all the way up and down. With these movements for strength, if there's any pain or if there's weakness, that's what's considered positive. And again, when I'm doing all these movements, we're looking at, can we isolate what muscle or tendon we think has been injured? So that's just kind of a quick exam that we might be doing in clinic when we see these patients. And it's all based on where these muscles and tendons attach, how they move, to figure out what exactly is going on with the patient. Thank you.
Thanks, John.
Okay, and now I'll get back to my screen. So this just kind of walks through what I did with John and gives you the idea of, again, I'm palpating, feeling for any tenderness or deformities. I do some range of motion, and then we do our tests for strength to better isolate what might be going on with the injury. So to move on to the acute injuries, one quick tip that tends to hold fairly true is when patients have a direct fall on the shoulder, if they're younger, so under 20 or 30, they tend to have more injured the clavicle. If they're 30 to 50 years old, the AC or the acromioclavicular joint is commonly the injured joint. And if they're over 50, it tends to be the rotator cuff. So before I even walk into a room, or if you're out on the hill and you've come upon a patient and you can guess their age, or they give you the age, this may actually help you narrow it down pretty quickly. It doesn't hold true all the time, but it is a pretty quick trick and it works well majority of the time. The specific injuries we'll talk about are your clavicle fractures, AC joint separation, shoulder dislocation, humerus fracture, and scapular fractures. So here's a picture of a clavicle fracture. That's right in the middle. It's obviously separated. And from the fall on the direct shoulder, the different areas where they can have fracture like this one, right in the middle or mid shaft, you can have it distally or more to the outside of the clavicle, and you can have it proximally or more to the inside. With the distal, the blood supply comes from medial to lateral or proximal to distal, and therefore it's harder to heal these areas. Plus, more distally is where all those ligaments and tendons attach, so it gets pulled apart more. The more distal it is, the less chance it has of healing as well on its own. Those are the ones that may need surgical repair. Midshaft or multiple fractures comminuted are ones, again, if there's a lot of separation or displacement, they may need surgery. The one to be aware of, if it's closer into the chest, that's an area that as you push on, it's really stable in there. You've got your ribs, you've got those ligaments. If there's an injury that causes a fracture in this area, you've got to be really concerned that there may be other associated injuries, either with the head, the neck, the chest, or even the internal or the visceral organs, because of the amount of impact it takes to break as you get closer into the midline. As you're pushing, again, watching for deformity or what we call tenting. So you'll see actually some spiking on the skin, and it may even be an open fracture. With any of these shoulders injuries, we want to make sure to check your motor and sensory and pulses below the injury. So anything, check the radial pulses and make sure that that's okay. Check their sensation. And again, with the clavicle, you're looking for breathing and lungs. That bone is close to where the lungs are. That bone is close to where the ribs are, and it can have more internal injuries. So be watching for that. With the clavicle, we see those, we'll put them in a sling after we've gotten the x-ray done. a regular sling, or there's the figure 8 ones that come around the back. Those can be pretty uncomfortable for patients. We rarely use those. And again, in certain cases, we'll refer those for surgery if they're more complex, displaced, distal, or proximal. Your AC joint separations often come in, these are pretty painful injuries. They are in a lot of pain when you do this. And they'll have to pain directly when you push on that AC joint. The other thing you may notice is they may have a bump, bulge, or step off right at the AC joint. When we do our x-rays, you can actually sometimes see separations as you get up to the type 2 and type 3 and above. This person here in this picture, obviously you can see there's a little bit of a step there, which isn't normal. That should be nice and level across like it is on the other side that's not injured. In type 1, they'll be tender when you push there, but on x-ray, it looks pretty normal. Maybe you see a little bit of widening side to side. On type 2 injuries, you'll see at least a halfway step on x-ray or widening, and that's because the ligament is torn right in the middle where the AC joint is at. And type 3 and above, you'll see a bigger step. It'll be the clavicle will be all the way above where the acromion is, and then it might even be higher than that. And that's because the ligaments right there have ruptured or torn, and then the ligaments, depending on how many ligaments, will give you a higher degree, but they've torn underneath the clavicle. So now there's nothing holding that clavicle down towards the rest of the shoulder. And as you get higher up in these injuries, they can be more severe, may require surgery. A lot of times with the AC joint, even though it looks awful, they won't repair these surgically unless you're a football player or a baseball player and that is your dominant throwing arm and you need that for your living. People will recover and do great. Their strength and range of motion comes back to normal. They may just always have this prominent bump on their shoulder. When people come in, I tell them kind of the rule of threes. It's really painful. It hurts like hell for 3 days. It's painful for 3 weeks, and full movement and strength may take up to 3 months to come back. So for these people, physical therapy can be really beneficial as part of their treatment. We'll put them in a sling for comfort, help with pain control. Again, it's really painful. And if it's a higher degree or there's any concerns of other involvement, they may need to be referred to ortho or surgery. So our favorite, we often see these on skiers, is your shoulder dislocation. They're great to reduce because the patient gets instant relief. Makes you feel like you've actually done something for them. It's not the patient's favorite. It really hurts while they're dislocated. But when you put these patients back in, it's instant relief and you feel like you've made a big difference for them. Shoulder dislocations account for 50% of major joint dislocations, and 25% of the dislocations have some other associated type of fracture or injury with it. We will always x-ray these people when they come in before we reduce it. If there's a big fracture in the humerus, especially the neck here, and you try to pull on it, you're causing more damage. So we'll always x-ray these people first. The different types of dislocation, anterior is the most common. When they come in, the arms maybe a little bit, it's against their body, but a little away from their body and kind of internally rotated. It's hard to see in this picture. The posterior dislocations, well, and again, you can see in this anterior dislocation, this gentleman with that's not the right looking shoulder. You can see the bone right there, which isn't normal, again, when you compare it to the other side. Posterior dislocations, you'll see a little bit more of a bony prominence posteriorly, and the front will actually look a little more flattened. And the inferior is where patients present with the arm above their head. And we often think posterior is above the head, but a lot of times posterior presents just like an anterior would. It just looks a little different, and x-ray is what gives us the difference. The inferior ones are the ones where it's more above the head. With dislocations, we really worry about the nerves. The bones have shifted, so it can cause problems with nerves. And then once you put the shoulder back in, you have to make sure that everything's stable with the nerves, that you haven't created numbness, tingling, or that if there is numbness and tingling, it resolves once the shoulder's back in place. Oftentimes, because the bone has moved so much, the rotator cuff has been torn in one way or another. So these are patients who need follow-up to make sure they recover and heal well. And there's a couple different lesions that you can see on shoulder dislocation. One is called a Hill-Sachs lesion, and you'll actually get a bony depression on the posterior superior part of the humeral head because of the impaction with the glenoid. Here would be kind of an example of a Hill-Sachs lesion in this image, and that obviously shows that the shoulder is outside. This is the glenoid up here, and this part of the humerus should sit right there in its little home and it's not there. A Bankart lesion is where you'll get a labral tear of the glenoid because, again, that movement. And those can make the shoulder a little bit more unstable once it goes back in, make it more likely to come back out. You can also get other fractures either of the glenoid or of the humeral head. And that's, again, why we do x-rays before. We repeat the x-rays after in clinic to make sure it's back in place, and again, to evaluate for any other injuries of the bones that might be there. Once we've put the shoulder back in place, we'll put them in a sling, and it's really important that they don't raise their arm up because it'll pop right back out. So they can go no further than 90, and even 90s pushing it a little bit because of the instability. They have to give it time to rest and let those tendons retighten and stabilize the shoulder. It's happened before where people come in, you tell them that, and they walk out and be like, well, they said not to, oh, yep, I'm dislocated again. They walk right back into the clinic. So it's important once they do that, we get the arm across the body, stabilize it, get them in a sling. We get them into physical therapy. And again, if there's other associated injuries, they may need to see ortho, or if they keep dislocating the shoulder, if they're doing it repeatedly or frequently, then they may need to do surgery just to tighten everything up and stabilize the shoulder again. So a couple of the main techniques that we use in our clinic are the Cunningham technique, which is where you have the patient sit face you, you place their hand on the shoulder with a little bit of downward pressure of your hand, and you use the outside hand to try to get that patient to relax the muscles along the trapezius, along the deltoid, and along the upper arm. When they relax, you can have them do a little bit of shoulder shrug up and back to get that scapula to rotate, or sometimes just once they relax, it clunks right back into place. And here is a video that shows, let's see, there we go, the Cunningham. It's an older video, obviously. So he's got the patient's hand against the shoulder. And then you can see with the outside hand, he's trying to get the patient to relax those muscles in the shoulder.
I don't see any
Using
video.
the provider's using a little bit of downward pressure with that inside hand right at the inward crease of the elbow. And with this one, the key is you have to have a patient who can relax. And you can sit there for a little bit of time, but if they don't relax, you're not going to be able to get it to go back in. It's the least traumatic reduction as far as you're not using other force to get it to go back into place.
Amy, we're not seeing the video.
Uh-oh. Thank you.
No problem.
Not now.
Perfect. We see it now. Yes.
Okay. So again, now you can see the shoulder of the patient, hand of the patient's against the shoulder of the provider, downward pressure in the elbow, and some gentle massage to try to get the patient to relax. And there it just went. So if I can,
Okay, so we'll pop this shot and swing now. Okay.
let's see. Just go back a little bit.
All finished. Okay.
Just you can watch again, and it happens right there. Just goes in, non-traumatic for the patient, and he's happy. And then the arm goes against the body to support it. Okay. And I'll go back to my slides. If you want to watch that link again, it is in, the link's in there, so you can watch that again too, but it's pretty undramatic when it reduces. The other main method we use is called the snowbird method. And that's where the patient is sitting straight up. We'll often have another patient using a sheet or towel to keep the patient upright. This picture shows the person or the provider behind them. I'll often stand in front or just off to the side facing the patient. You'll use a strap that goes right at the hinge of the elbow. You'll get the patient to kind of bring the palm upward, again, elbow against their body, and then you'll do some outward rotation of the arm as you're doing the downward traction. And with the strap, you can often step in it. So this picture shows the lady stepping right into the strap to do the downward pressure, and then she's doing the external rotation. Oftentimes, this lower picture shows we'll have a third person on the back doing what we call a scapular tilt. And by tilting the scapula, again, the scapula is one of the biggest parts of stabilizing the shoulder joint. So by having them do the scapular tilt, where you get your fingers right underneath the scapula and you're doing kind of tipping or rotation of the scapula, it helps the humerus slide right into the shoulder joint. So this takes a few more people. It's a little bit more forceful, but in those people who can't relax, this method works well. There's a number of other methods as well out there, but these are the two most common ones that I use in the clinic and that I've seen other providers use. So moving on to humerus fractures. A lot of these patients, again, it's painful. They're holding the arm against the body. They do not want to move their arm. So this is someone I'm going to do the x-ray before I do range of motion and my other tests, just because they don't want to move it. And there's different parts. It's called the Neer classification. This picture shows kind of a modified version of it. But obviously, again, you've got the one part where you've got a fracture in one area, 2-part fractures, 3-part fractures, 4-part. And the further out you get, the more severe it gets. A lot of times with these, the one part are the most common. 80% of them are the one part in the Neer classification, and they'll heal on their own. The biggest thing with these injuries is you'll put them in a sling and immobilize them, but you don't want to immobilize them too long, no more than 2 weeks, or everything starts to freeze or lock up in the shoulder, and that can create more problems. So not lifting is a big part of their recovery, and that you start range of motion pretty quickly. And physical therapy, again, can be a great place to get them back with range of motion and strength as quickly and safely as possible. Pain, a lot with not just these injuries, but any shoulder injury, it's painful to lay back or lay flat. So sleeping up in a prop chair or a recliner. Pain control with the fractures is a big one. And these can take time. These can take up to 8 to 12 weeks to fully heal. So a little bit longer healing time than some other fractures. Scapular fractures, as shown in this picture, you can see right down the middle of the scapula, and then that little sharp edge there is where the scapula has been fractured. This takes a lot of force. It's direct force or fall onto the scapula. Again, if somebody's got a scapular fracture, you need to be checking for other injuries because of the amount of force it takes to do these. And with skiing injuries, you'll actually see the glenoid neck can get fractured. That's one of the more common ones if people injure at skiing. If you've got the clavicle fracture in combination with the scapular fracture, it can be what's called a floating shoulder. With both the fractures, you lose all stability and the shoulder is just kind of floating in place without being attached or held in. And that can be pretty problematic. In these cases, it's mostly with the scapula. It's a big bone. It's supportive treatment, sling, rest, pain control, position of comfort, and allowing it to heal over 4 to 6 weeks with close follow-up. If there's a lot of displacement or separation in the fracture, then those are people who need to be referred. And if we see a scapular fracture, we're most often sending these to ortho anyway to be followed for healing, because if they're not healing correctly, they may need surgery. So to move on to a scenario, if you're on the hill, you get a call that comes in on the radio that there's an injured skier about 3 to 4 towers down from the top of the lift. You arrive on scene and your patient is a young adult male. He's sitting up, holding his left arm against his body, rocking back and forth. He is alert and oriented. He's visibly very uncomfortable, but he is able to talk to you and answer questions. He says his left shoulder really hurts. Nothing else seems to be bothering him. So with these patients, it's just like any of your other patients on the hill. You're going to go through your scene safety, your primary assessment, secondary assessment, and then transport and get them off the hill as quickly as possible. So scene size up. In this case, you're under a chairlift, so you want to make sure you cross your skis above you or get some other patrollers or mountain hosts or other people to help so you don't get run into by somebody else coming down the run. And first and foremost, once you've done your scene safety and scene size up, you do your primary assessment. As I mentioned before with the shoulders, you've got to make sure the breathing and the airway is okay. And don't forget to check the C-spine. So you go through like you normally would. Check airway, he's talking to you, that's good. He's breathing. You don't notice any obvious bleeding, but you can do a quick check, palpation with the hand once you put your gloves on. Again, check the C-spine and shoulder injuries. The circulation is really important. So even before you're checking things, a quick way to check circulation is have them squeeze your hand or tapping on the hand to see if they can feel it, and looking for any other disabilities. You can then move on to your secondary assessment and reassess any vital signs. So at that point, you can try to get in there and check a radial pulse. Again, a quick review of the ABCDs, making sure that their level of responsiveness is okay, running through your circulation, motor, sensory, and document any changes as you go. Then you move on to your DCAT BTLS. So this is the case where you go and you can kind of focus your exam pushing around the shoulder. Do you feel any deformities? In this case, you don't notice any obvious deformities in him. As you're pushing, you don't feel any crepitus. If you're able to visualize, you don't see any bruising on him. There's no visible abrasions or punctures or bleeding that you note. You don't see any bruising, as I said. He is tender, and it's kind of a general tenderness, but definitely around the AC joint is where he seems most tender. You can check temperature. The skin there feels the normal temperature, and any obvious swelling or symmetries. So you can do a quick, if you're able to, in an area where you can expose, compare both sides and see if there's any asymmetries or differences. Then you're able to ask your sample questions. So signs and symptoms, he's already said that his shoulder really hurts. He says he can feel a little bit of numbness in his hand, but he can move it okay. When you ask about allergies, he has allergies to penicillin, no other allergies. He doesn't take any medicine normally. For past medical history, he's injured his left knee and had a meniscus repair, but no other surgeries or other medical history. He ate lunch about an hour ago, and he remembers everything that happened. He caught an edge, fell, landing right on that left shoulder. And then you're able to get the patient in a comfortable position and transport. So don't forget with these patients that you need to really check for any other injuries. So as you're palpating around, you're checking the neck, the shoulder, pushing around the arm, push along the chest and lungs, push on the belly and the back. If they've fallen, there may be other injuries there. So a quick push and check of all the other areas of the body to make sure you're not missing anything else. Also really important, again, that sensory circulation, motor, sensory, to recheck that intermittently and see if anything's getting worse. And with these patients, the position of comfort is what you want. Most of the time, it's not going to be laying down. It's going to hurt them to lay down. So a sitting up position. So just that this page kind of reemphasizes what I just mentioned, that again, it takes a lot of impact to cause shoulder pain. So checking for other multiple injuries. A lot of times the shoulder pain is really bad and it might distract from other injuries. So that's why it's important to make sure you're checking around. Always focus on the airway and the breathing, checking the lungs. Again, the clavicle is right next to the lungs. There may be a punctured lung, and always checking that C-spine. The neck pain can radiate into the shoulder. So if they're sore in the shoulder and you can't find a point tenderness, you may find more point tenderness in the neck, and then you need to stabilize the C-spine and you'll be transferring in a different way. With transporting, like I said, they're probably going to be more comfortable sitting up, and you want to stabilize the shoulder first. You've been trained and are really good with doing good slings. So your sling and swath, if the patient's more comfortable with the arm away from the body or above the head, you've got, like in this picture, the option to do a towel roll. You can roll up a towel or a blanket, and then you can do your swath right over it or a sling outside of that to stabilize and hold the shoulder and arm against the body so it's more stable. The flying arm are the wooden splints that can bend, and that can keep the arm up above the head or further up. And before and after splinting, you want to check your CMS to make sure that you don't compromise anything and there's nothing worse after you've splinted or repositioned anything. I know that there's the option to do sitting, so you can put one of the sled packs behind a patient, the sitting chairs, if you need to call for other patrollers to bring that down to you. You can even have another patroller sit behind this person and just help hold them up and stabilize them if you need to. And just be aware that all the little bumps you hit when the shoulder is dislocated or there's a fracture or AC separation are really going to hurt these patients. So give them the smoothest ride you can while getting them down in a timely way and safely. So just in summary, the shoulder is a complex joint. There's a lot going on. It helps to understand the basic anatomy and physiology of the shoulder. I gave a quick demonstration of what I would do in a clinical exam. We talked about some basic acute injuries that are commonly seen, and we went through an on-hill scenario and the assessment you would go through, focusing on additional injuries to watch for and the importance of how to transport these patients. Any questions?
I don't see any on the chat. Does anyone have any questions? Otherwise, I'll say a few things. Well, I'll just start and please stop me. First of all, Amy, that was just great. You can tell that you've learned your anatomy, and that was really good. And thank John again for doing that. I have a few words to say about just our particular situation. The first thing is that, you know, if you ask me what my favorite injuries are when I deal with skiing stuff, it's shoulder injuries. If you said why, well, it's first of all, it's so, as you said, I want to reinforce, when you put someone's shoulder back in who's dislocated, it's just instant feeling from the worst pain comparable to delivering a baby. I've had mothers tell me that they've had a dislocation in a baby and a baby also, and that they're about the same amount of pain, but at the end of the end of the delivery, they had something to show for it. At any rate, putting someone's shoulder in is the only time I've ever been kissed by a male. So I certainly haven't forgotten that. I also want to reinforce what you said about how you have to, once they're in the sling and swath, after you've relocated, that they have to stay that way. Because one of the funniest things that ever happened, it could only happen to a doctor. I had a doctor come in with a dislocated shoulder. I put it back and I said, now I'm gonna put you in a sling and I want a swath. I don't want you, moving your arm. And he goes out to his car and he comes back in. I had to relocate it because of course he had to see if he really could do it. So, you talk about a theoretical, I've actually seen that exact thing. The other thing that is real important, sometimes asking, as Amy instructed you to about the past history, sometimes if you have a suspicion, ask them if they've ever dislocated before. And it's amazing how many say, oh yes, I have. And you know that that's a very likely diagnosis. But the most important thing that I want to tell you is two things. First, as we talk about with every one of the acute injuries we see, what you see first is really important to us. So that initial pulse and that initial neuro exam are very, very important because you're the snapshot. And by the time they get to us, if something has changed, that's really, really important to us as far as how urgent it is to get something done. And then the last thing I want to tell you are just as I've told you many times, I encourage you always when you come upon a patient, either from the history and the physical exam, even though you're out in the field and you can't sometimes take the jacket off because it's too cold and you want to get out of there, still you should always try and guess if you can see what the diagnosis is. And the thing about shoulders, I'm going to give you a couple things that I consider really fun that you might be right probably 75% of the time. The first thing you need to realize that anyone who has a fracture, a broken bone, what do they want to do? They don't want it to move. So what happens with someone who has either fractured their clavicle, fractured their humerus, fractured their glenoid, even their scapula, they will take their arm and hold it up against their body. I'm going to show you here. I'm going to come back on again here. So you probably can see me someplace. They are holding it like this because they don't want to move. The problem is you can't stop breathing. So they still move. But if they're splitting it against their body, it makes you think that they might have a fracture. The next thing is something that's really fun. If you notice, and I have to stand up. If someone is holding their arm up, like they're pushing up, you have to think of an AC separation because the weight of the arm pulling it down, that causes more pain. So they're trying to make it up. So if you come upon a patient who, feels like it hurts a lot, especially when it just hangs or they want to be leaning against something, think of an AC separation. And the most important one, the fun one, as I've told you before, are dislocated shoulders. And though sometimes they're close to the body, almost always they're holding it and it's away from the body. And they're trying to make little adjustments because the dislocated shoulder, they want to make it better, and they keep trying to find a better spot. They don't until it's relocated. But it really hurts them. If you try and push it into the body, they don't want to go there. They want to hold it there or wherever it is. They don't want to move it because, you know, it's away from the body, and the way it's impacted underneath there, they can't actually get it against their body for the most part. So if you see any of those three things, you can make a good guess that, you know, it's either AC separation or a dislocated shoulder or a fracture. That's how I distinguish them, trying to make a field diagnosis, and you can be right maybe 3/4 of the time. The other thing is that I often see or hear, you know, someone says, oh, I feel the divot, and they think it's a dislocated shoulder, but yet the patient comes in and they're holding it up. And you need to be able to distinguish from the AC joint, where the divot is right where Amy was showing you where the AC joint is, and the shoulder where the divot is down low. So it's often mistaken. And the other big thing is if you just look at their face too, fractures hurt, dislocations hurt more. So enough for what I have to say. Does anyone have any other questions? If not, we'll let you go. And I want to thank Amy again. That was just great. Okay, I just see lots of thank yous for you, Amy, and I'd add my list to that as well. So we can stop recording and everybody can leave, and I'm going to talk to Sue.